I'm Professor Fidelma Dunn and I'm a consultant endocrinologist at Galway University Hospital. I've been looking after ladies who have diabetes in pregnancy for 20 years and with my colleagues have developed this web set of videos to provide education for you, the person with diabetes, so that you understand the importance of preparation for pregnancy, regular attendance during the pregnancy and a follow-up visit post the delivery of your baby for ongoing care. The number of women in Ireland with type 2 diabetes is increasing. If you have type 2 diabetes, your pancreas isn't working at 100%. Therefore, the production of insulin from your pancreas is reduced, though not eliminated. In addition, the insulin that is produced from your pancreas is not working efficiently. This is called insulin resistance. If you have type 2 diabetes, you are at increased risk during the pregnancy. However, we can minimize these risks by close attention to your diabetes management and in particular your blood sugar levels. At pre-pregnancy care, we examine your blood sugars and the treatment that you are on. As you have type 2 diabetes, it's likely that you are on tablets to control your sugars. However, these tablets are generally not suitable during pregnancy. And at the pre-pregnancy clinic, we will change you from the tablets to insulin treatment to normalize your sugars before you become pregnant. The insulin treatment will continue for the duration of the pregnancy, and post your delivery, we will change you back to your tablets again. During pre-pregnancy care, we will also prescribe for you folic acid 5 milligrams by prescription. This is important as we know it is associated with a reduction in the risk of congenital malformations in your baby. We will also check the rest of your medications that you may be on for diabetes, as a lot of these are not friendly for pregnancy. In particular, tablets associated with control of blood pressure and control of cholesterol. We will prescribe for you more pregnancy-friendly alternatives. A lot of time will be spent discussing your weight and how we can reduce your weight to ensure that it is normal before you become pregnant. We will also do a number of blood tests. These will check your thyroid function, your kidney function, your hemoglobin to make sure you're not anemic, and your overall diabetes blood test, which is called your HbA1c. We will give you targets for your sugar, which we like to be less than 5, fasting in the morning and before your meals, and as close as possible to 7, 1 hour after your meals. We will also tell you that the best HbA1c to achieve before you become pregnant is 6%. We will focus on smoking and alcohol, as these are not good for pregnancy. You will have an individualized dietary assessment with our dietitian, and our diabetes nurse specialist will spend a lot of time with you trying to help you to manage your sugar more effectively and deal with hypoglycemic episodes. Your care will now transfer from the pre-pregnancy service to the antenatal service. However, it will generally be the same people looking after you as we employ a team approach. The people you will see are a diabetes physician, a diabetes nurse specialist, a dietitian, a midwife, an obstetrician and an ultrasonographer. It is very important that you attend the clinic regularly and your appointments will be given to you every 2 to 4 weeks as required. At each clinic visit, we do a number of routine checks. These include your weight, your blood pressure, a check of your urine, and regular blood tests of your sugar control. We review your medications and we adjust your insulin to ensure that we keep your sugar tests normal. You will have scans carried out routinely at different times during the pregnancy. Initially, the first scan is to ensure that the date of your pregnancy is correct. This is important when we are organising the time of your delivery. The next important scan is in the middle of the pregnancy, and this is to have a detailed look at your baby to make sure that everything is developing normally. Towards the end of the pregnancy, we do more frequent ultrasounds, and this is to ensure that the growth of your baby is occurring at the normal rate and as planned.
I'm Breda Kerwin. I'm a diabetes nurse specialist. You will probably have met a person like me throughout your pre-pregnancy care who will follow you through your antenatal care and delivery, who will personalise your care with a multidisciplinary team and help you achieve your goals. As part of your package, we will highlight some issues which may arise throughout your pregnancy, which will have to be dealt with promptly and correctly. Hypoglycemia, an event which often occurs in the first trimester, where we're keeping very tight control on your sugars. We will have prepared you and your partner and your family to detect, treat and prevent this occurring.
Hypoglycemia. Hypoglycemia, or hypo, is the term used if your blood glucose levels go too low, below 3.5. This can happen for a number of reasons, such as delayed or missed meals, not eating enough, vomiting, too much exercise at one time, inaccurate dosing of insulin, alcohol, hot weather, breastfeeding. You'll learn how to recognise your own early warnings of a hypo, and these may include nervousness or anxiety, shakiness, sweating, tiredness, confusion or hunger. If you experience any of these symptoms, you should do a blood sugar test to check your level. If your level is below 3.5, you're having a hypo. To treat your hypo, take 15 grams of fast-acting carbohydrate that contains sugar, and this is provided by one of the following: 5 glucose tablets, 100 ml of Lucozade, 150 ml of pure fruit juice, not diet, or a sugary drink such as Coke. Follow this with a slower acting carbohydrate like fruit, bread or breakfast cereal. Check your blood glucose levels again after 10 or 15 minutes. If you're still below 3.5, repeat the treatment and test again until your level comes up. Remember to always carry glucose tablets or some form of sugar with you. Severe hypoglycemia. If the episode progresses very quickly or the warning signs are ignored, you may not be able to administer your own treatment. You may have to rely on family or friends, which is why it's vital they understand what to do. The signs and symptoms of a severe hypo include poor concentration, slurred speech, glazed eyes, poor coordination. You may appear to be drunk, confusion, drowsiness, or a loss of consciousness. Immediate action must be taken. If you're conscious and it's safe to swallow, have some sugar. The liquid form is easiest. Or 15 grams of fast-acting carbohydrate, glucose sweets, sugary drink, fruit juice, and once you start feeling better, check your sugar. Again, follow this with a slower acting carbohydrate like fruit, bread, or breakfast cereal. Explain to your family and friends what to do if you pass out or become unconscious, which is the following: place you in the recovery position and inject you with glucagon. If glucagon is not available, call 999 immediately for medical help. Insulin should never be given to an unconscious patient. Always report a severe hypo to your nurse or doctor.
Hyperglycemia ketoacidosis, a serious medical condition. This indicates that your body is lacking your essential insulin, which also creates a state of dehydration in your body. This condition, if untreated, allows your body to develop acidosis, which can be threatening to your unborn baby and also to the maternal health. This can be caused by nausea, vomiting, an untreated infection like a urinary infection, or omission of your insulin. In preparation for your pregnancy, we have given you the skills to help you cope with detecting and treating this type of condition. If you have detected high blood glucose levels, and we have instructed you on blood testing for ketones and urinary testing for ketones, and if they are positive, action must be taken quite quickly. If you're unable to eat or drink or keep any solids in your body, it's very important that you are admitted in a hospital setting. Ketoacidosis, prevention, early detection and prompt treatment will greatly reduce the serious risks posed to your unborn baby and also to mother. Morning sickness, which can often last for up to 16 weeks. Once the first trimester is completed, hopefully this will leave. If the symptoms are severe and you're unable to eat or drink or you become ketotic, it's very important that you seek urgent medical advice and treatment to correct this condition in your body. Preeclampsia, a medical condition which usually occurs in the last trimester of your pregnancy, associated with an elevated blood pressure and also the detection of protein in your urine. You may also have some swelling of your lower limbs and fluid retention. This condition warrants that you will have to have treatment, i.e. an early delivery of your unborn baby or medical treatment in hospital requiring stabilisation of your blood pressure. Retinopathy and nephropathy. Two conditions, if you have already existing eye disease or kidney disease, may deteriorate throughout your pregnancy with extra demands of the pregnancy. We will monitor very closely. In each trimester, your eyes will be screened, and at each clinical visit, we will screen your kidneys. Early detection of deterioration of these conditions will be promptly treated by your physician. Preterm labour. This term describes a labour which has occurred before the baby is fully developed. It may occur before 37 weeks gestation. In this instance, your baby may require specialist treatment in the special care baby unit. Polyhydramnios, an increase in the amniotic fluid, the fluid in which your baby floats. This can indicate poor glycemic control and often prompt a premature labour. But with the increasing of your insulin doses and better glycemic control, often this polyhydramnios can be reduced.
As part of your specialist care, you'll be given advice on regular activity and exercise. And the reason for this is we know that it lowers blood pressure, it helps control cholesterol, it helps your blood sugars, and many, many more important factors. To get the benefits, you'll be advised to do 150 minutes spread over the week of moderate intensity activity. So one example would be 30 minutes a day. It's important to start off gradually and build up slowly, picking gentle activities, things like walking, swimming. You can seek advice from specialist care. The most important thing is it's enjoyable, it fits into your daily routine. Irrespective of the type of diabetes, it's important to check your blood sugars before and after you exercise. And you may need a snack in order to help prevent low blood sugars. It's important if you're on an insulin pump that you think about checking your basal rate for exercise purposes as well. You'll be getting more advice on a one-to-one consultation to give you a personalised programme to help you get the most from your activity.
A diabetic should always follow a healthy, balanced diet, but this is especially important during pregnancy. Follow a healthy, balanced diet. Eat regular meals with a small portion of high-fibre carbohydrate food at each meal. Eat plenty of vegetables and limited fruit. Avoid added sugars in your diet. Breakfast needs to be small. A healthy diet contains a balance of foods to support baby's growth. The food pyramid is a good guide of how much of each food you need every day. Your dietitian can help you with meal plans that suit your own needs. There are 3 basic nutrients in food: carbohydrate, protein and fat. Carbohydrates provide us with most of our energy. Carbohydrate foods turn into sugar or glucose after you eat them. It's important that these foods are eaten in small quantities throughout the day. Include a small portion of starchy carbohydrate at each meal. Choose high-fibre, whole grain options. Protein is essential for your baby's development. Protein is found in meat, chicken, fish, eggs, peas, beans, lentils, tofu, nuts and cheese, and will not turn to sugar when you eat them. Fats do not turn to sugar, but should be limited in your diet. One special fat, omega-3, should be increased in your diet. The best source are oily fish, such as salmon, trout, mackerel, sardines, kippers and herring, and you should aim for 1 to 2 portions of oily fish per week. Vegetarian sources of omega-3s include soya, walnuts and rapeseed oil. The following are types of carbohydrate foods: starches, milk and yogurt, fruit. Starches. A small portion of high fibre carbohydrates should be eaten at every meal. Milk and yogurt are good sources of calcium. Choose sugar-free yogurts, diet or light, and limit your milk to no more than 3 glasses of 200 ml each day. Eat plenty of vegetables and a limited amount of fruit. It's best to avoid fruit juices and smoothies. Avoid dried fruits such as raisins, sultanas, dates and apricots, and eat only 1 piece of fruit at a time. Avoid added sugars in your diet. Sugar and sugary foods like chocolates, sweets, cakes, honey, jam and fizzy drinks, and sugar and chocolate coated breakfast cereals. Avoid foods labelled diabetic or made with sugar alcohols like sorbitol, malitol, xylitol. They're often high in fat and can cause wind bloating and diarrhea if you eat a lot of them. Some medicines, like medicines for heartburn and constipation, contain sugar. Make sure all the medications you're taking are sugar-free. Speak with your doctor or pharmacist about sugar-free options that are safe in pregnancy. Include a small breakfast each day. Blood sugars tend to be higher in the morning. In summary, to keep your blood sugar levels under control during pregnancy, eat 3 meals and some snacks spaced evenly over the day. Limit portions of carbohydrates. Avoid added sugars and sugary foods. Include a small portion of starchy carbohydrate at each meal. Limit fatty or fried foods and takeaways. Do not skip meals and drink plenty of water and other sugar-free drinks throughout the day.
Throughout your pregnancy, you have been treated with insulin for your type 2 diabetes. At the time of delivery, you will continue to use your insulin and monitor your sugars regularly as normal. This will continue right up until you are in active labour if you're having a normal delivery. As you've had type 2 diabetes, your care has been closely monitored during the pregnancy. Continuing in this fashion, your obstetrician and his team will decide on the most appropriate form of delivery for you, taking into consideration your health and the health of your baby. The majority of women deliver at term, which is considered to be 37 to 40 weeks. There are a small number of women who need to be delivered before term, and this delivery is sometimes warranted if your health or the baby's health is at risk. If your delivery happens at term, you may go into labour normally yourself and have a normal vaginal delivery. This happens in the majority of women. Should this be the case with you, you will continue to take your insulin as prescribed and as planned until you are in the active stage of labour. At that point, the midwife looking after you will change you to a drip which contains glucose and insulin. This is important as the midwife will then be able to regulate your blood sugars between 4 and 7 for the duration of the delivery. You will not need to worry about your blood sugars or about your insulin yourself. It is important to keep your sugar during this important period of time between 4 and 7 to ensure that your baby's sugars are normal when it is delivered. If your obstetrician decides that a caesarean section is the best form of treatment for you, this is usually planned and you will be given a date for this delivery. You will be brought into hospital generally the night before, and you will continue to do your own insulin and your own sugar testing up until the time you go to sleep. After that, you're not allowed to eat or drink. On the following morning, the midwife or doctor in charge of your care will put you on a drip early in the morning. This will contain glucose and insulin, and once again, the doctor and the midwife caring for you will regulate the drip and the insulin to keep your sugars normal. You will not need to think about your sugar or your insulin requirements yourself. Similarly, if your obstetrician decides that he needs to induce your labour, you will continue to take your insulin as prescribed normally until the induction of labour has placed you into the active stage of labour. Following delivery, when you are eating and drinking again, the drip containing the glucose and the insulin will be discontinued. It is advisable that you carefully monitor your sugars in the first couple of days following delivery. If you intend to breastfeed, it would be recommended that you continue with small amounts of insulin and adhere to your diet during the 3 to 6 months that you wish to breastfeed. The reason for this is that the tablets you would normally take outside of pregnancy may not be the most suitable for the baby as they pass through the breast milk. On the other hand, if you decide to bottle feed your baby, you will continue with your diet and resume your usual anti-diabetic oral medication. We recommend for all women with diabetes, but especially for women with type 2 diabetes, that you breastfeed. This has very good benefits for you in terms of reducing your blood sugars and reducing your body weight. It is also very beneficial for your baby, both in the short term and in the long term. You will come back for your postnatal visit to the diabetes service. This is very important again. At this visit, we will examine again your blood sugar control and change you back from insulin to your tablets for the ongoing management of your diabetes. We will also check your blood pressure, your kidney function and your eyes, and we will ensure that your name is placed on the list for routine ongoing diabetes management. We will also reinforce the principles of pre-pregnancy care so that you are aware of the names of the people involved and the contact numbers should you wish to become pregnant again.
Hello, my name is Caroline and I'm a type 2 diabetic. I was diagnosed 10 years ago. It's a genetic disease that's in our family. I started attending the normal diabetic clinic shortly after I was diagnosed, and whilst the experience was nice, I didn't realise at the time until it was mentioned to me that there was a pre-pregnancy diabetes clinic also in operation in the same centre. It was, as I said, it was mentioned to me a few times on a different all through the years, but because I thought that I was healthy enough with my diabetes sugar levels under control, and I thought that I was trying to get my weight under control, I didn't feel the need at the time because I wasn't planning an immediate pregnancy, and I was under the illusion that it was just for pre-pregnancy people or women that had diabetes that were actually pregnant at that moment in time. So last year it was mentioned to me again because I am a woman and I'm a child within childbearing age. And I said, okay, well, you know, there's no harm in seeing what this is all about. So I went. I found the experience very exhilarating. I thought it was a session or that it was going to be a talk, and I actually found that I was speaking to one of the doctors and I got a one-to-one personal care. While I thought I was healthy, I wasn't. My blood sugar levels weren't within the range that should be for a woman that is considering a baby. And my weight, I was overweight, and a lot of the things that they mentioned, I knew then by coming away that I knew if I was to fall pregnant at that moment in time that it would have had serious complications for myself and my baby if I were to continue with the pregnancy and for it to go to full term. So I'm still with the pre-pregnancy clinic. My circumstances have changed. I'm not planning on becoming pregnant, but if the inevitable happened and I did become pregnant, I know I have the support and care of the pre-pregnancy diabetes team, and I know that I would be given one-to-one care. I enjoy coming back to the clinic. I can talk about my fears about pregnancy. I can talk about my fears of the diabetes and my own experience, and I've got to know the staff on a one-to-one basis.